So for the cortisol levels, and so kind of like the conversation dealing with the intersection between biological mechanisms and social determinants of health. So as it relates to the cortisol, the weathering term, do you believe that folks are born maybe through epigenetics? Do you believe people are born with a higher thermostat for maybe cortisol upregulation or other inflammatory hormones? Maybe going two or three generations. And so when you're born, you already kind of like have a high thermostat. And then when you have to deal with various environmental stressors, because your thermostat is already set high, you are in a different space, which makes you more susceptible to various cancers and other diseases. So just curious to hear your thoughts about that.
Okay. All right. So it takes a minute to wake up. So maybe it's on the West Coast time like I am. But thanks for raising the question. There are, several, I think, really intriguing findings around, exposure to adverse life events and then epigenetic changes. And I'm not aware that I can cite specifically about studies that have looked at epigenetic changes related to cortisol. But I would suspect that, adverse child experiences, is important to epigenetic changes. And so I would anticipate that we would see some of those similar changes, within the HPA axis response.
Okay.
And I guess, I would love to have some conversation because I think, there's this, as we ask those questions, like, are people born with the higher thermostat, right? Which is then it's like, well, what do you do to change that thermostat? Do you change it? That's where my interest would, my sort of head would go as a first thought. It's like, well, how do you change that thermostat? Are people who have stressful experiences, either in utero or as young children, are they just, is that just it for them? Can we not, help to implement strategies to mitigate that? And so that's where I think, we have to begin thinking about, different types of approaches. So, for intervention, perhaps maybe on the more complementary alternative side about, stress management. There's really compelling data showing that yoga, for instance, really does reduce cortisol levels in cancer patients in particular. And so if we begin to think, because I feel like, maybe the reason why I'm not a geneticist. Mm-hmm. I work with a lot of colleagues who are. Mm-hmm. But I guess I'm like, well, what are we going to do about it? Is where I would go.
Right. And what made me think of that question I asked you is because I just remember I teach classes, and one of the classes I teach toxicology, it talks about how animals that get exposed to pesticides like atrazine, you can see effects on the animals 2 or 3 generations out. So like the grand generation, who's never seen atrazine before, is being impacted by the grandmother or grandfather mouse that got exposed to atrazine. So I was just thinking about, in terms of your cortisol comment, could there be also opportunities, or not opportunities, but could there be a similar situation?
I would a
grandparent
agree.
who was born in slavery or something.
Yes, absolutely. Yeah. And I think those are the questions that are really a priority for examining. One, because I think it helps to, in my mind, one of the arguments now about why there's, I've heard some groups say, well, we have to move beyond like slavery and segregation, but they have downstream long-term effects. And I don't know that we completely understand the physiological consequences with empirical data. That, and so I think those studies are really important. So we have something to talk about, Antonio.
Right. Cool. Okay. I warmed the crowd up. It's all you know.
Hi, Dr. Halbert. Thank you for that presentation. Very informative. And I love that you're working with FQHCs in the Los Angeles area, because our community level HCPs need just as much education and support as the community does. Because of my own hardships, both directly and indirectly, I often tell myself that cancer doesn't discriminate, but policies and practices do. And my question for you is, what policy changes do you believe need to happen in order to make translational research more equitable in breast cancer?
Yeah, thank you. So I think that policy is a couple of ways. So, one is my first thought for your question is, it's really around the policy around what type of research do we prioritize and who's involved in the research that we do. So I think NCI has really, and NIMHD has really been at the forefront of requiring that for certain types of mechanisms, you have to have community engagement. For certain types of mechanisms, you have to have an educational component. For certain type of mechanisms, you have to demonstrate your capacity to be able to do this research effectively and successfully. And so I think that's one policy that I think NIH has, some institutes at NIH have really been at the forefront of developing and instituting. I think at the healthcare system level, some of the ways in which, we have, and I'll speak for, having been at a couple of different places over a period of time. I think that, some of the policies are around, well, what type of information is collected around our patient characteristics. So, one example, and I'll just say maybe before and after, like mandates were issued around collecting information on social risk factors and screening patients for social risk factors. That didn't exist, but that's now a policy. How healthcare systems are responding to it is all over the place. But I think the fact that the policy exists and there's an expectation that healthcare systems will be held accountable for demonstrating that they have some metrics, some information that goes beyond, the clinical care is important. And what I've learned just speaking about FQA, working with FQAC sites is that, and this has been shared with me from some of the medical directors, like, they prioritize what HRSA says is required reporting. And so if we think about, well, how can we establish policies around required reporting and who that reporting goes to, I think is sort of what I think would be really sort of important next steps. Yeah.
Cool. Next question.
I thank you very much for your presentation. What I wanted to do, I work at Sloan, certain things I learned, I would not have known it if I was not at Sloan Kettering. And whatever I learned, I try to teach in my faith-based communities certain things. Because in spite of the political discourse that puts a lot of people under stress, by the way, I try not to listen to it, it's a lot of noise. What affects one affects the other one. We pay for it when people are sick in our community with our taxes. People on Medicare, Medicaid, who pays for it? Taxpayers' money, am I right? So I teach people in my community for free, diabetes, how you can avoid it, et cetera, et cetera. Because at the end of the day, like Dr. Martin Luther King Jr. says, if we don't learn how to live with each other, we're going to perish like a bunch of fools. The Black person or the Hispanic person or the immigrant, whatever, illegal alien works for you, if they're not healthy, they're going to call out a lot and we all going to lose. So that's why whatever affects minorities, migrants, it's going to affect all of us. And I tell people, no matter where you stand on the aisle, I don't care about that. A human being is a human being. If we all do well, society as a whole will be well. Thanks again for your presentation.
Yeah, I'll just.
Hi, good afternoon. Thank you so much for your presentation. I took so many pictures. So I am a public health doctoral student here, and my research, I had to write it down because I'm also tired. So my research focuses on getting Black men through the door of the doctor's office. So that first kind of step for cancer screenings, among other screenings for disease risk factors. And I thought it was interesting to not see prostate cancer on the list of kind of hotspots that the Ralph Lauren Cancer Center focused on. And so I was just curious about that. And then the kind of follow-up question is wondering if there's anything that's come out of your research or your work in general that could help us understand more about the barriers and motivators to cancer screenings. And of course, I'm going to look for your papers, but just curious what you've seen.
Sure. So the first question is why are we not addressing prostate cancer within the Ralph Lauren Center? So that was really based on the capacity that we had just to work within the space. So part of the one of the things that I think we were thoughtful about is, you know, we were very specific and intentional in wanting to build sort of draw the connection between primary care and oncology care. And just based on the state of where our partnerships were with FQHC sites, we just don't have one that currently focuses on that. So they focus on breast, cervical, lung, and colorectal cancer. So it's really just an issue of strategy. And I think, you know, the other thing that played into our mind, and I'll just say this, I mean, one thing that, you know, we all have to kind of be cognizant of is, you know, I believe in prostate cancer is a really important disease. And I think no one would disagree with that. But we were sort of centered on screening. And I think there's still some controversy about prostate cancer screening that, you know, we knew how our application was going to be reviewed. And we wanted to, you know, be effective and not have to, you know, make the argument about why we were focusing on prostate cancer. Having said that, I have a whole area of research that focuses on prostate cancer. So it's, you know, it's all things come when they're ready to come. And then the second question, I lost sight of it. What was? Yeah, so it's, you know, it's an interesting thing. I mean, I think, you know, the early research would tell us that it was, you know, the main barrier was, you know, around the procedure itself. And I think, you know, that in my mind, many interventions have, you know, been effective in sort of addressing that as a barrier. And so now we have, you know, PSA screening, which was, you know, always a complement and offered and provided along with prostate cancers with the digital rectal exam. So here's what I think is important now because, you know, the guidelines are like, well, men should make an informed decision about prostate cancer screening. That's what all the guidelines say, or many of the guidelines say that. And so the question about making an informed decision, if you talk to a provider, well, how do you talk to men about prostate cancer screening? They either say you should have it or you shouldn't, or say nothing. And so there's a process and some specific methodologies that go along with informed decision-making that I don't think have really made their way into primary care practice. And I think that's the biggest barrier. So, you know, and I think, in my opinion, it's sort of moved to this space of, you know, you have providers who typically do it, and then there are those who don't. And I think if men don't ask for it, they don't get it. So the question then becomes, well, how do you address that? One of my colleagues who leads the California Black Health Network, Rhonda Smith, they developed an approach that's called How Do I? And what I think is really powerful about that is that it's a strategy that can be adapted to multiple types of health services. And if you think about, well, if you were to sort of build upon that and think about, well, these are we need to be better prepared, I think, as healthcare consumers when we go into the doctor's office, and not just have it be a one directional that the provider is telling you what's going to happen, but you really sort of guide patients as consumers, guide the discussion and say, these are the things that I want to know that, you know, we're paying attention to.
One more question. Oh, okay. I'm sorry. Okay.
Hi, Good afternoon, everyone. My name is Christelle Pierre. I currently work at the Arthur Ashe Institute for Urban Health within the Community Engagement and Research Core. And as many have said, thank you so much for your thought-provoking presentation. And the question that I have for you is, you mentioned that recruitment is a significant challenge in clinical trials, and there's a significant need for the design recruitment strategies or tailored to the community at hand, especially recognizing the history of, I guess, like the historical traumas that are involved within clinical research and medicine within the Black community. Have you considered, or is this engaging community-based organizations within the community, especially through the Ralph Lauren Cancer that you guys lead? Have you guys tapped into community-based organizations as a way to engage community, as a way to bring them into cancer trials, given that they are trusted entities within the community?
We have. And so I guess we've done it in a couple of ways. One is, I think the partnerships that we have with our federally qualified health centers, although they're health centers, they're community-based. And so that is one type of community organization that I think has been extremely instrumental to the work that we do as part of our Center for Cancer Prevention. I think the other partnerships with faith-based organizations, with public health groups, and with, community, and I guess I'm thinking about neighborhood associations as another type of community organization, are all important. And I think it really depends on the goal of the study, the individuals who are like the focus of the research. And so, I'll illustrate an example. So I think if we're doing work that's targeting that where cancer patients are the population of interest, then I think we really do have to be in an oncology setting. If the populations of interest are community residents, then the community organizations, really outside of the FQHC sites, but really in the community, would be the way in which I think it's important to think about, the recruitment strategy. So it's really about matching, the goal of the study, the goal of the research with the entities that exist within the broader landscape of our healthcare system, public health practice. So just as an example, I started my career doing research on decision-making about genetic testing for inherited breast cancer risk. And this was, in the early 2000s when BRCA1 and BRCA2 were just being, the clinical practices were just beginning to get aligned with offering genetic counseling and testing. And so one of the groups that was contracted to work with our institution was like, well, we should go to faith-based organizations, we should go to health fairs. I'm like, well, that's all great, but if you're really wanting to demonstrate and improve access to the populations that will be aligned with how genetic testing is offered, which is, women who have a personal or strong family history of disease, then we want to be in the oncology setting because that's where those women are. And it sort of came to, the outcome data demonstrated that for sure, because even in our own work, we found that we were most likely to identify women who were candidates for genetic testing and mammography or the cancer treatment setting versus in like internal medicine, family medicine, sort of the general primary care practices. And so that just illustrates, I think, that we really want to be sort of focused. If the metric is how many people enrolled in a study, we want to be focused. I think there's an important role for partnering with all groups to share information. And that's really goes across the board. So it's not to say you can't have one without the other.
Yeah, I would like to just make sure we give some attention to our online participants. So we have a comment. Thank you, a very thought-provoking presentation. Love that photo with you and your mom. And then the second one, Thanks for mentioning partnering with CBOs, Brooklyn Public Library Community Health Partners, with organizations to bring info and resources to underserved communities. So just want to bring attention to those chat messages. Let's give our speaker another big hand.